Okay, you guys, let's talk about the elephant in the room. And a matter of fact, she's not even an elephant anymore. She's a big old herd. Now, for some communities, the sirens are going off because, and how do I know this? I know this because did you hear about HR 3518? And what is the demographics of the top 10% of the population? I'm not insured under Medicare. I get private insurance. And so it's not my problem. But oh, yes, it is. And when there is a medical desert, people don't survive. Are you a little bit overwhelmed with all of the healthcare changes? Don't worry, you're not the only one. But I'm here to break it down for you in a two-part series where I walk you through some of the most critical potential health policies that are coming your way and share with you how these policies may impact your family. Grab your cup and sit back because we're going to be in for a little bit of a bumpy ride. We thank you guys for joining us, and don't forget to do what? Click subscribe. Y'all, we have a lot to talk about. We have a lot to talk about. Let me get myself together for y'all. I am Dr. T, and I am here to give you the medical updates on what the health crisis is going on. And I'm going to do it in just over a minute because I got a lot to say, you guys. We got a lot to talk about. So why don't you get comfortable? Go ahead, come on in. Everybody's welcome. Have a seat, get comfortable, because we're going to be in here for a little bit as we talk about some of the most important updates that you need to know. Now, granted, some of you may be aware of some of the updates that we're going to be talking about, and that's okay. My goal today is to apply what you have heard, give you some context to it so that you can fully understand what's going down. That's right. Go ahead, get comfortable. Okay, you guys, I am certain you have been probably, if you're like the rest of us, a little overwhelmed with just the volume of information that's going out and trying to really comprehend what does this really mean for me in my household. There has definitely been a lot of changes going on, and my goal today is just to jump right into it and give you guys some of the really key updates. We're not going to be able to touch on everything, and believe me, there is lots to touch on. One topic I will not be able to touch on today, but I'm hoping to come back and touch on this topic is a lot of the environmental justice issues that are taking place that are really not getting a lot of public media attention and are in fact affecting significantly pockets of community, predominantly people of color, predominantly Black people. So I'm not going to be able to touch those issues today. However, I do promise you, I will definitely come back and touch on the environmental issues. And that's going to be major because it's those type of issues that result in generational diseases and compromise and health issues and health crises that stem back to a particular time where a policy was changed or where some type of measure was made or some company came into the neighborhood. We're going to get back to that. But definitely today, what I want to focus on is I want to focus on some of these broader health policies and bills that are being slid under the cover so that you don't know that they have been written and that they have been brought to the attention of Congress. Because Congress isn't talking about everything, y'all. They're talking about some things, and some things have caught their attention and they are worthy of attention grabbing. But there are other bills that are just as critical in terms of how they can potentially impact our lives if they are passed that no one's really talking about. Let's get into it. Okay, you guys, let's talk about the elephant in the room. And a matter of fact, she's not even an elephant anymore. She's a big old herd. But we're going to talk about her first. So, what do you guys think about the Medicaid or potential Medicaid cuts? Now, for some communities, The sirens are going off because we know how wide and broad the impact of such cuts can be for our populations. Well, you guys, they are thinking about cutting almost $800 billion from the Medicaid budget in over the time period of 10 years. And so what does that mean for the average American? Well, first let's talk about how many people are actually on Medicaid. So it's estimated that 1 in every 5 Americans is actually insured by Medicaid. That amounts to about 72 million Americans based on 2023 data. So when you think about it, you're talking about just significant amount of communities with potential impact. And of course, you guys know I'm going to have to break this down to maternal health because we will never forget the maternal health. Okay. Okay. So it is known that 41% of all births are under Medicaid. And specifically, when you look at people of color, and we're going to focus on Black women because we know that the maternal health crisis disproportionately affects Black women, that number is increased to about 64%. So almost 2/3 of all Black women delivering in America are insured under Medicaid. So the cuts to Medicaid can potentially mean millions and millions of pregnant women will not have access to this affordable insurance. The reason why the Affordable Care Act was part of its goal was to expand Medicaid, was really to expand the affordability of healthcare so that impoverished or vulnerable populations would have more access to affordable healthcare, and also not just individuals, but small businesses as well. And so when you think about just the sheer numbers of individuals that can be potentially impacted, it's really mind-blowing. But here's the kicker too that many people don't really think about, because some people may say, well, I'm not insured under Medicare. I get private insurance, and so it's not my problem. But oh, yes, it is. And I'll explain to you how. Well, we know a lot of Medicaid practices or Medicaid reimbursement rates are adopted by private insurance. So the private insurance industry oftentimes will look towards Medicaid to determine how they're going to proceed. So what that means is that, oh yes, honey, your premium is likely to go up as a result of these changes, even though you are not insured by Medicaid. Here's another kicker that a lot of people don't really pay attention to as well. So did you know that one of the issues or one of the motivations to decrease the uninsured population? Well, we would love to think that it is all benevolent, but there's actually a fiscal aspect to it. We know that when there is a higher rate of uninsured populations, we have an increase of ER visits. Yes, I remember when ER visits were ballooning and the ERs were overwhelmed. But not only that, when you have individuals who are underinsured or uninsured, what do? They wait till the last minute to get help, just simply because they can't afford healthcare. The word on the Medicaid street is that if people are kicked off, people who are deemed ineligible to be on Medicaid may not be able to access health insurance otherwise. And what hasn't been talked about is whether or not there's going to be a removal of the penalty for not having insurance. And so people may lose their insurance, can't get new insurance, and then be penalized for not having insurance. Oh, yes, it's a big deal. This is why we need to pay attention. And the other part of it that you should be mindful of is not just the ER visits, but the fact that when there is delayed care, which oftentimes when you're uninsured or underinsured, you're less likely to seek preventive care. So instead of preventing diseases, you wait for the treatment of the condition or the treatment of the disease. And oftentimes people wait until the very last minute in which they end up presenting with advanced disease or advanced stage conditions. So instead of having early breast cancer, they have late breast cancer. Instead of having early renal disease where it can be medically managed, they have late onset or end stage renal disease. What happens when there is an overutilization of the emergency room and an underutilization of preventive care services, you have a ballooning of the cost of healthcare. And healthcare, when it balloons, can wreck an entire government. So let's talk about this from a more epidemiological perspective. So what happens when you have fewer people on Medicaid? And what happens when potentially Medicaid reimbursements, which is the other part of the equation, are cut? Well, a lot of our community hospitals and our rural hospitals are dependent on this program. And so they are dependent on the program directly and indirectly. One, they are dependent on the Medicaid program for reimbursements, right? So a large percentage of their payments or revenue, or the ability to operate as a nonprofit, if they are in fact still a nonprofit, comes through the reimbursements from programs like Medicaid and other insurances. Then when you talk about indirectly, you're talking about just the volume of patients, right? So if fewer people in that community have access to health insurance and have access to be insured, then you have a underutilization of your services. So you may have hired the best cardiovascular surgeon in the country, but guess what? Because the volume is just not there, you can't support that specialist income. And so you have twofold things that may happen. The first level of an operational disaster is the fact that now you can't recruit in certain communities certain specialists because specialists, as you know, get paid more than your primary care physician. I will talk a little bit more about the primary care physician crisis, essentially, that's happening. But if you can't, and one of the ways that they justify or are able to pay the higher income of specialists is by making sure that they have a population that's going to utilize the service. Well, if you don't have a population that is well insured, then they're not going to be able to afford the services provided by the specialist, even if they have the disease, even if they have to come to the emergency room at the last minute because they're having a massive heart attack. If they're not insured and they are underemployed, they might not be able to pay that bill. So you have a hospital with a whole lot of IOUs, even if the services are warranted because the condition is prevalent in the population. So, for example, if you have a population that has a high percentage of coronary artery disease, so they're more likely to have a myocardial infarction or heart attack, they may utilize the services of an interventional cardiologist. But the problem is that they're oftentimes going to present with end stage disease or condition. So when they're having the massive heart attack, as opposed to when they're having angina, where they can undergo interventional services or medical management to prevent the massive heart attack. So they come in with the massive heart attack, they overutilize services because now they're critically ill, which requires much more intensive care, requires sometimes one-on-one nursing, which is much more expensive for a hospital. So if a hospital then have a population that has a prevalent outcome because they can't turn them away, which is something else I'm going to talk about in a little bit. There is a federal law that says regardless of how someone shows up, either they can pay the bill or they can't pay the bill. They are obliged, the emergent services, to take care of them. And so it doesn't matter who they are, except there's new controversy about that when it comes to women's health, but I'll talk about that in a little bit. And so the hospitals will take care of them and then they can't pay the bill and the hospitals are left with outstanding bills. They're not getting their revenues from the direct population because they're having a decline in the utilization of their services, but they're having an overutilization of emergent services, which are way more expensive. And then they're getting low reimbursements the from Medicaid. And so what ultimately happens is, especially when you speak of vulnerable populations, you have closures of hospital, closure of clinics, closure of hospitals, closure of ambulatory services, closure of ambulatory surgical centers, you have closure of dialysis units, you have closure, and it is a domino effect. And ultimately, what happens is you have these communities that have these basic medical deserts. And when there is a medical desert, people don't survive. And I'm not saying that lightly at all. And the reason why, okay, so let's get into why people may not survive, right? So we'll stick with the cardiac issue for a minute. It is understood that if someone is able to get care within 90 minutes of the start of their symptoms, that they are more likely to survive. Well, given the fact that a lot of people don't realize when they're having a heart attack or a stroke, you'll oftentimes just have even a half of that time spent as people starting to realize that something serious is going on. This is why it's CPR this is why in the process of providing CPR, it's really important to activate the medical system very early and to activate life-saving measures such as using an AED, simply because the time is so short to improve someone's survival rate. When the ambulance is able to arrive on scene, but now has to travel another 15 minutes, another half an hour, another 45 minutes to the nearest hospital, there are people who just will not survive that delay. And when you do arrive to the hospital, the question is, who's going to take care of you? Oh, that's another question. Who is going to take care of you? Let me explain. So we know that there is an ongoing shortage of physicians in general, not just in the United States. This is an international problem. There's an ongoing shortage of physicians around the entire world, but the US is no exception. And especially in certain fields like obstetrics, women's health, for the obvious reasons, that has been magnified with fewer people going into the field because of the obvious reasons, which we're not going to get into in this video because it's just that is a video on its own, but also because of just the sheer difficulty of becoming a primary care physician. So primary care physicians are some of the lowest paid physicians in the US. And even though you will see a range of primary care physician salary based on where they're located, are they at an academic center? Are they more rural? Are they in a metropolis area? Are they in the countryside? So it really does make a difference. And the salaries, people will be surprised, for a family medicine physician can start as low as $41 per hour, according to the US Bureau of Labor Statistics. And so that will surprise people. And some people may say, oh, $41, at least it's more than minimum wage. But when you're talking about a group of people who have delayed their income to do the long journey of becoming a doctor and then have acquired just massive amount of debt, it is really hard to pay back. And unfortunately, once you get the degree, there's a certain lifestyle that's almost expected, and it doesn't account for just the variability of incomes in the field. And so things like our licensure are really expensive, and things such as, going even to conference to keep up with the latest medical information are really expensive. Going to or paying for publications are really expensive. And so you have to be able to afford those things in order to really be at the forefront of your profession. But let's get into the part where we talk about just the astronomical debt that are incurred as a result of this beautiful journey of becoming a physician. Let's talk about the debt. So, did you guys hear about the proposed bill that puts a cap on loans that can be taken out for advanced education. Did you hear also about the limitation for a loan forgiveness program? Well, let me explain to you why this is really important to pay attention to. When you have a cap on getting loans to attend medical school and other professional schools, then you are ultimately putting a cap on the individuals, or you're restricting the individuals who can go into that profession. And let me explain why. According to the AAMC, the average cost of attending medical school, which includes not just the tuition, but cost of living expenses, is as much as 68,924. And that's the average, right? When you look at the median cost for the years of attending medical school, the median amount of debt is $268,000. And that's going to vary depending on whether or not someone is going to an in-state school or an out-of-state school, going to a state-based school or going to a private school. And so that amount can balloon up. I mean, I can definitely tell you, I know individuals who have left medical school with debts up to $400,000 and $500,000. So yes, for some people, the cost of medical school and the cost of having advanced degrees can be as much as paying for a house. Not the mortgage of the house, a house. Okay. So it is very, very expensive. So being able to have access to loans, because who has that kind of money just available to pay for the ongoing expensive of the ongoing expenses of attending these schools? Very few people in the population. So you're talking about maybe the top 10% of the population may have access to that type of income. And some would even say fewer than that, but I'm going to be liberal with my estimates and say the top 10% of the population. And what is the demographics of the top 10% of the population? And that alone will tell you that if this bill passes and this clause is still a part of the bill, then you're going to have a drastic amplification of the current shortage of family medicine physicians, because you can't pay back that kind of debt on a family medicine salary without having access to loan forgiveness programs when you're working in community centers, which also gives you a lower salary. And so if you have fewer family medicine physicians just because the salary sucks, and you don't have access to funding to be able to fund your career, then you're going to have fewer doctors. When you have fewer doctors, you end up having long wait times. So it won't be unusual to have to wait until next year for your annual visit. Your annual visit may be now called your every other year visit, because there just will not be enough physicians to be able to deal with the population that requires these annual routine visits to make sure that everyone is able to have access to preventive care. Instead, you're going to have a ballooning of specialists because you're going to have a larger population who have chronic diseases because simply they cannot get into their doctors, who are primary care physicians or family medicine physicians specifically, who are able to screen them for these diseases and help them to make lifestyle changes so that they don't develop diabetes, so that they don't have hypertension and all of the sequelae that potentially come with that. Because even when you're diabetic, you may not get in to see your podiatrist, right? If there's a shortage of physicians. And here's the thing, some people will say, well, utilize more nurse practitioners and more physician assistants. Great idea if they are already certified now. But their schooling also costs. So, and their schooling is also very expensive. And so this impacts not just your physicians, but the entire broad stroke of healthcare, including your nursing schools, right? Because they are not cheap either. And also just the practicality of it all. You can't have adequate NPs and PAs to fill the gap of primary care physicians if they're not already trained. This is a now problem. It is not a just a future problem. And so, as you know, what would be the demographics of the new generation of doctors? I would definitely tell you they are not looking for anyone that looks like your girl. And how do I know this? I know this because did you hear about HR 3518? Listen, child, they're going in with this one. If the message wasn't clear before, let this make the message even clearer. So, this is a proposed amendment. Okay. So, this is a proposed amendment to the Higher Education Act of 1958. Listen, this is what they want to do. They want to cut funding to any medical school that supports DEI. Listen, and this is how they're planning to do it. A medical school will lose their funding if they do any of the following. One, if they have a DEI office, if they have instructions that talk about DEI, if they have special programming, if they have diversity statements in their admission process, and if they include the acknowledgement of race or diversity when it comes to the practice of medicine. So, why is this important? Well, it is important because we know in medicine there has been just layers of historical data that tells us that different populations are affected by different conditions. And the inability to recognize race will make it impossible to take care of populations adequately who have diverse genetic makeup, diverse environmental exposure, diverse chronic diseases. For example, when we look at our maternal health crisis, we know that Black women are disproportionately affected by the maternal health crisis. Well, if you do not have instruction or research or policies that are able to address that, then you're not going to have a resolve of the crisis. In fact, it probably will get worse. And so far, statistically, we're showing that the crisis is getting worse. But part of the solution is to retrain the newer generation of healthcare providers so that they're able to care for diverse populations. Because currently, the America I know is diverse, which means it requires the ability and the training to be able to take care of that population. So apparently the goal is not to take care of a diverse population, just so that y'all are aware of that. So the goal right now is probably to raise a generation of physicians who are not trained to take care of a diverse population, but to take care of a monolithic or what they perceive to be a monolithic population. But we all know those genes are mixed up, even though they may be expressed differently, because race, as we know, is a social construct. There is no biological basis for race. It was set up to it was set up to create social status and to separate individuals. And that's all that it has been doing. Race has no effect on your genetic makeup. What has an effect on your genetic makeup is your exposure, is how your race is treated. Y'all got the difference? It is not that you are Black, but it's because you are Black having a Black experience in America that you have certain outcomes. That's what the impact of race is. But innately, there is nothing that says Black people are more likely to have high blood pressure. No. What happens is Black people are more likely to experience blood pressure issues simply because of their experience in America, which goes from the food that we're exposed to, the stress that we endure, and the historical trauma that are in our genetics. That's all it is. So that's another health change that you should be aware of. But I got more. Is it time for another sip of our tea? Because we got more to talk about. Hey, you guys, I had so much more to share. Make sure you join us for the next episode. I want you to leave your comments below. This is a community. We've been sitting down like family and having this conversation together. Now I want to hear from you. I've been talking for a little bit. Now I want to hear from you. So make sure you leave your comments below. Let us know what your thoughts are. And maybe you are someone who may have a solution. Do you have a solution to some of these healthcare problems? Oh my gosh, I definitely want to know that. And I'm looking forward to seeing you when on the next episode. And this is Dr. T, the hand behind the handle of Healthy Bump Club right here on YouTube and Healthy Bump Club on Instagram. We thank you guys for watching. We hope to see you guys on the next episode. And this is Dr. T, just a friendly reminder. Don't forget to comment, like, and share. And go ahead, why not? Click that subscribe button. Help us to get to the next 1,000 subscribers. We thank you guys for supporting.